serous endometrial carcinoma. Serous endometrial carcinoma generally occurs in women who are about 10 years older than those with endometrioid carcinomas, and in contrast with endometrioid carcinoma, they usually arise in the setting of endometrial atrophy. See Figure 22, 24b. Serous tumors are considered type 2 tumors and are, by definition, poorly differentiated, grade 3. They account for approximately 15% of cases of endometrial carcinoma. This subtype shows significant morphologic and biologic overlap with ovarian serous carcinoma. Pathogenesis. Serous endometrial carcinoma is highly associated with disruptive mutations in the TP53 tumor suppressor gene. TP53 mutations are present in greater than 90% of tumors. Most consist of missense mutations that result in the accumulation of the altered p53 protein. Figure 22, 26b and d. Genomic sequencing studies have detected driver mutations in a number of other cancer genes. See Table 22.4. In addition to point mutations, serous carcinomas typically are associated with significant chromosomal instability and numerous copy number alterations, a general feature of TP53 mutated cancers. All serous carcinomas belong to the copy number high serous-like molecular category. Mutations in TP53 are also found in approximately 75% of endometrial intraepithelial carcinomas, an in situ precursor lesion, suggesting that mutation of TP53 is an early event in the evolution of serous endometrial carcinoma. The tumor presumably arises as a surface epithelial neoplasm that then extends into adjacent gland structures and later invades endometrial stroma. Their generally poorer prognosis is thought to be a consequence of a propensity to exfoliate, travel through the fallopian tubes, and implant on peritoneal surfaces like their ovarian counterparts. As a result, they have often spread outside of the uterus at the time of diagnosis. A B-C-D figure 22.26 type 2 endometrial carcinoma. A. Endometrial intraepithelial carcinoma, the precursor to serous carcinoma, showing malignant cells arrow with morphologic features identical to serous carcinoma, lining the surfaces of the endometrial glands without obvious stromal invasion. B. Strong, diffuse expression of p53 as detected by immunohistochemistry in endometrial intraepithelial carcinoma. C. Serous carcinoma of the endometrium, with papillary growth pattern consisting of malignant cells with marked cytologic atypia, including high nuclear to cytoplasmic ratio, atypical mitotic figures, and hyperchromasia. D. As with the previous lesion, there is an accumulation of p53 protein in the nucleus. Chapter 22, the female genital tract. Morphology. Generally, serous carcinomas arise in small atrophic uteri and are often large bulky tumors or deeply invasive into the myometrium. The precursor lesion, serous endometrial intraepithelial carcinoma, consists of malignant cells identical to those of serous carcinoma that are confined to the epithelial surface. See Fig. 22.26ab. The invasive lesions may have a papillary growth pattern composed of cells with marked cytologic atypia, including high nuclear to cytoplasmic ratio, atypical mitotic figures, hyperchromasia, and prominent nucleoli. See Figure 22.26cd. However, they can also have a predominantly glandular growth pattern. In such cases, they are distinguished from endometrioid carcinoma by the marked cytologic atypia. All of the tumors in this category are classified as grade 3 irrespective of architectural pattern. Serous carcinoma, despite relatively superficial endometrial involvement, may be associated with extensive peritoneal disease, suggesting spread by routes, i.e. tubal regurgitation, other than direct invasion. Clinical features. Carcinoma of the endometrium is uncommon in women younger than 40 years of age. The peak incidence is in postmenopausal women 55 to 65 years of age. There is no currently available screening test. Although it may be asymptomatic for a period, it usually produces irregular or postmenopausal vaginal bleeding. Fortunately, postmenopausal bleeding often leads to early detection, and cures are possible in most patients. The diagnosis must be established by histologic examination of tissue obtained by biopsy or curettage. At the time of diagnosis, endometrioid carcinomas are analyzed for evidence of DNA mismatch repair defects because approximately 3% to 5% of women with endometrial cancer have Lynch syndrome and are at high risk for colon carcinoma. As would be anticipated, the prognosis depends heavily on the stage at diagnosis, as well as histologic grade and subtype. The staging system for endometrial adenocarcinoma is as follows. Stage 1, carcinoma is confined to the corpus uteri itself. Stage 2, carcinoma involves the corpus and the cervix. Stage 3, carcinoma extends outside the uterus, but not outside the true pelvis. Stage 4, carcinoma extends outside the true pelvis, or involves the mucosa of the bladder or the rectum. In the United States, most tumors, about 80%, are stage I well-differentiated or moderately differentiated endometrioid carcinomas. Surgery, alone or in combination with irradiation, gives about 90% 5-year survival in stage 1 grade 1 or 2 disease. This rate drops to approximately 75% for stage I, grade 3 tumors, and to 50% or less for stage 2 and 2 endometrial carcinomas. As mentioned, serous carcinoma has a propensity for extrauterine, lymphatic, or transtubal spread. For unknown reasons, it occurs more frequently in women of African American descent, a difference that accounts for a twofold higher mortality rate in African American women with endometrial carcinoma compared with Caucasian women. Overall, the 5-year survival for women with serous carcinoma is 18% to 27%, and even when it is confined to the uterus, the recurrence rate is as high as 80%. Treatment varies according to tumor type. Women with endometrioid carcinoma often receive adjuvant radiation to reduce local recurrence and are treated with chemotherapy when the tumor has spread beyond the uterus. By contrast, because of the aggressive nature of serous carcinoma, women may be treated with chemotherapy, even in the absence of detectable extrauterine spread. Inhibitors of the PI3K/AKT pathway are being tested in clinical trials, and the continued identification of biologic targets is likely to expand the roster of rational therapies in the future. In addition, immune checkpoint inhibitors are under investigation for the treatment of women with tumors in the hypermutated MSI and ultramutated polymerase epsilon molecular categories. Carcinosarcoma, malignant mixed Müllerian tumors. Carcinosarcomas, also referred to as malignant mixed Müllerian tumors, are mixed epithelial and mesenchymal tumors. The epithelial component most often resembles poorly differentiated endometrioid or serous carcinoma, while the mesenchymal component can take a number of forms. Some contain uterine mesenchymal elements, stromal sarcoma, leiomyosarcoma, while others contain heterologous malignant cell types, rhabdomyosarcoma, chondrosarcoma. Based on molecular studies showing the presence of shared driver mutations, the epithelial and mesenchymal elements appear to be derived from a single founding cancer cell. The mutations found in carcinosarcomas involve the same genes that are mutated in endometrial carcinoma, such as PTEN, TP53, and PIK3CA, whereas alterations typical of sarcomas are absent, suggesting that these tumors are carcinomas that have acquired the capacity for mesenchymal differentiation. At present, the mechanisms underlying the sarcomatous transformation are unknown, but some abnormality of epigenetic regulation seems likely. Morphology. Carcinosarcomas are often bulky and polypoid, and they may protrude through the cervical os. These tumors usually contain areas of adenocarcinoma, endometrioid, serous, or clear cell, mixed with the malignant mesenchymal sarcomatous elements. Figure 22. The tumor may contain two distinct and separate epithelial and mesenchymal components. Sarcomatous components may also mimic extrauterine tissues, e.g., striated muscle, cartilage, adipose tissue, and bone. Metastases usually contain only epithelial components. See Figure 22-27b. Carcinosarcomas occur in postmenopausal women and present with bleeding. Outcome is determined primarily by depth of invasion and stage. The only other known prognostic factor is the differentiation of the mesenchymal component. Patients with tumors that have heterologous mesenchymal components have a poorer prognosis than those whose tumors do not. Overall, 5-year survival rates are 25% to 30% for patients with high-stage disease, 1,012, body of uterus and endometrium, 1,013. A B figure, 22.27 carcinosarcoma. A micrograph showing both malignant epithelial and stromal components. B lymph node metastasis from a carcinosarcoma, showing only the epithelial component, as is typically the case. Key concepts: endometrial carcinoma. Endometrial carcinoma is the most common malignancy of the female genital tract. There are two major types of endometrial carcinoma, type I and type 2. Type 1 tumors are low-grade and usually indolent. Type 2 tumors are high-grade aggressive tumors and have a poor prognosis. 4 molecular subtypes of endometrioid and serous carcinoma are currently recognized. Endometrioid type 1 carcinoma is often preceded by atypical hyperplasia and commonly has mutations that upregulate PI3K. AKT signaling. Serous type 2 carcinoma is associated with serous endometrial, intraepithelial carcinoma, and the most common mutations are in TP53. TP53 mutations are also found in precursor lesions. Stage remains the most important factor in outcome. Serous tumors are much more likely to present at advanced stage and have a decidedly worse prognosis. Carcinosarcomas are aggressive tumors that resemble endometrial carcinoma genetically and have poor outcomes with current therapies. Tumors of endometrial stroma. These relatively uncommon tumors comprise less than 5% of endometrial cancers and include stromal neoplasms admixed with benign glands adenosarcomas and pure stromal neoplasms. Adenosarcoma. Adenosarcoma presents most commonly as large, broad-based endometrial polypoid growths that may prolapse through the cervical os. The diagnosis is based on the presence of malignant appearing stroma, which coexists with benign but abnormally shaped endometrial glands, These tumors predominate in women between the 4th and 5th decades and are generally considered to be a low-grade malignancy. Recurrences develop in 1/4 of cases and are nearly always confined to the pelvis. The principal diagnostic dilemma is distinguishing these tumors from large benign polyps, stromal tumors. The endometrium occasionally gives rise to neoplasms that resemble normal stromal cells. Endometrial stromal neoplasms are divided into 2 categories: 1 benign stromal nodules and 2 endometrial stromal sarcoma. Stromal sarcoma may be further divided into low-grade and high-grade types depending on their differentiation. Clues to the pathogenesis of stromal sarcoma have come from the identification of several recurrent chromosomal aberrations that are quite specific for these malignancies. As with many sarcomas, stromal sarcoma is associated with chromosomal translocations that create fusion genes. Low-grade endometrial stromal sarcoma usually has a translocation in which a portion of the JASF1 gene, which encodes a transcriptional repressor, is fused to a second gene belonging to the polycomb gene family, such as SUS12. Polycomb proteins participate in complexes that introduce repressive histone marks into chromatin, thereby silencing genes. And it is hypothesized that the JASF1 fusion proteins act by disrupting the function of the polycomb complex, leading to misexpression of oncogenic genes. Recently, high-grade endometrial stromal sarcomas have been observed to contain different chromosomal translocations that also result in the formation of fusion genes, which are presumed to be pathogenically significant but are currently of unknown function. About 1/2 of stromal sarcomas recur. Relapse rates range from 36% to more than 80% for stage 1 and stage 3 V tumors, respectively. Unfortunately, relapse is not reliably predicted by either mitotic index or the degree of cytologic atypia. Distant metastases may announce there. Chapter 22, the female genital tract. Presence decades after the initial diagnosis, and death from metastatic tumor occurs in about 15% of cases. The 5-year survival rates average 50% for low-grade tumors and are lower for high-grade tumors. Tumors of the myometrium, leiomyoma. Uterine leiomyoma, commonly called fibroid, is perhaps the most common tumor in women. They are benign smooth muscle neoplasms that may occur singly, but more often are multiple. Most leiomyomas have normal karyotypes, but approximately 40% have a simple chromosomal abnormality. Several cytogenetic subgroups are recognized, including tumors with rearrangements of chromosomes 12q14 and 6p involving the HMGIC and HMGIY genes, respectively, which are also implicated in a variety of other benign neoplasms. Both genes encode closely related DNA binding factors that regulate chromatin structure. Additionally, mutations in the gene MED12 occur in roughly 70% of uterine leiomyomas. MED12 encodes a component of mediator, a multiprotein complex that stimulates gene expression by serving as a bridge between transcription factors and RNA polymerase. Mice expressing mutated forms of MED develop uterine leiomyoma, proving that such mutations can be causative, but precisely how they contribute to tumor development remains to be defined. Beneath the serosa subserosal, Fig A, the characteristic whorled pattern of smooth muscle bundles on cut section usually makes these lesions readily identifiable. Large tumors may develop areas of yellow-brown to red softening. Leiomyomas are composed of bundles of smooth muscle cells that resemble the uninvolved myometrium. Figure 22, 28b. Usually, the individual muscle cells are uniform in size and shape and have a characteristic oval nucleus and long, slender, bipolar cytoplasmic processes. Mitotic figures are scarce. Morphologic variants include leiomyoma with bizarre nuclei, which has nuclear atypia and giant cells, and cellular leiomyomas. Both have a low mitotic index, helping to distinguish these benign tumors from leiomyosarcoma. An extremely rare variant, intravenous leiomyomatosis, is a uterine leiomyoma that extends into vessels and spreads hematogenously to other sites, most commonly the vena cava and the right atrium. Another variant, disseminated peritoneal leiomyomatosis, presents as multiple small peritoneal nodules. Both are considered benign despite their unusual behavior. Uterine leiomyomas, even when large or numerous, may be asymptomatic. Common signs and symptoms include abnormal bleeding, urinary frequency due to compression of the bladder, sudden pain from infarction of a large or pedunculated tumor, and impaired fertility. In pregnant women, leiomyomas may increase the frequency of spontaneous abortion, fetal malpresentation, uterine inertia, failure to contract with sufficient force, and postpartum hemorrhage. Malignant transformation to leiomyosarcoma is extremely rare. Morphology, leiomyomas are sharply circumscribed, discrete, round, firm, gray-white tumors, varying in size from small, barely visible nodules to massive tumors that fill the pelvis. Except in rare instances, they are found within the myometrium of the corpus. Only infrequently do they involve the uterine ligaments, lower uterine segment, or cervix. They can occur within the myometrium intramural, just beneath the endometrium submucosal, or these uncommon malignant neoplasms are thought to arise from the myometrium or endometrial stromal precursor cells, rather than leiomyomas. In contrast to leiomyomas, leiomyosarcomas have complex, highly variable karyotypes that frequently include deletions. Like leiomyomas, a subset contains MED12 mutations, a genetic aberration that appears to be virtually unique to uterine smooth muscle tumors. 1014. A B figure 22.28 leiomyomas of the uterine myometrium A, the uterus, is opened to reveal multiple tumors in submucosal, bulging into the endometrial cavity, intramural, and subserosal locations that display a firm white appearance on sectioning. B. Leiomyoma showing well-differentiated, regular, spindle-shaped smooth muscle cells associated with hyalinization of uterus and endometrium. 1015. A B. Figure 22.29, leiomyosarcoma. A. A large hemorrhagic tumor mass distends the lower corpus and is flanked by two leiomyomas. B. The tumor cells are irregular in size and have hyperchromatic nuclei. Numerous mitotic figures are present. Arrows. Morphology. Leiomyosarcomas grow within the uterus in two somewhat distinctive patterns. 1. Bulky, fleshy masses that invade the uterine wall, or 2. Polypoid masses that project into the uterine lumen. Figure 22.29a. They exhibit a wide range of cytologic atypia, from extremely well-differentiated to highly anaplastic. Figure 22.29b. The distinction from leiomyoma is based on nuclear atypia, mitotic index, and tumor necrosis. With few exceptions, the presence of 10 or more mitoses per 10 high-power 400 fields indicates malignancy, particularly if accompanied by cytologic atypia and/or necrosis. If the tumor contains nuclear atypia or large epithelioid cells, 5 mitoses per 10 high-power 400 fields are sufficient to justify a diagnosis of malignancy. Rare exceptions include mitotically active leiomyomas in young or pregnant women, and caution should be exercised in interpreting such neoplasms as malignant. A proportion of smooth muscle neoplasms may be impossible to classify and are called smooth muscle tumors of uncertain malignant potential. Leiomyosarcoma occurs both before and after menopause, with a peak incidence at 40 to 60 years of age. These tumors often recur following surgery, and more than one half eventually metastasize hematogenously to distant organs, such as lungs, bone, and brain. Dissemination throughout the abdominal cavity is also encountered. The overall 5-year survival rate is about 40%, but the anaplastic lesions have a 5-year survival rate of only 10% to 15%. Key concepts. Endometrial stromal tumors include stromal nodules, low-grade stromal sarcoma, and high-grade stromal sarcoma. Stromal nodules are benign, well-circumscribed tumors. Low-grade stromal sarcoma resembles stromal nodules but infiltrates into the surrounding myometrium. It is associated with fusion of the JASF1 gene and various polycomb factor genes, usually SOS12. High-grade stromal sarcoma shows marked atypia and is associated with other gene fusions. Both low and high-grade stromal sarcoma are prone to late recurrences. Leiomyomas are very common benign smooth muscle tumors that cause significant morbidity, but are not prone to malignant transformation. Leiomyosarcoma, a malignant smooth muscle tumor, is an uncommon, highly malignant myometrial tumor that usually arises de novo. Body. Fallopian tubes. The most common disorders affecting the fallopian tube are infections and associated inflammatory conditions, followed in frequency by ectopic tubal pregnancy and endometriosis. Inflammations. Suppurative salpingitis may be caused by any pyogenic organism. In some cases, more than one organism is involved. Gonococcus is the causative organism in more than 60% of cases, with chlamydia being responsible for many of the remaining cases. These tubal infections are a part of pelvic inflammatory disease, described earlier in this chapter. Tuberculous salpingitis is rare in the United States, accounting for not more than 1% to 2% of all forms of salpingitis. It is more common, however, in parts of the world where tuberculosis is prevalent and is an important cause of infertility in these areas. 1016, Chapter 22, the female genital tract. Tumors and cysts. The most common primary lesions of the fallopian tube, excluding endometriosis, are minute, down 0.1 to 2 cm translucent cysts filled with clear serous fluid, called paratubal cysts. Larger varieties are found near the fimbriated end of the tube or in the broad ligaments, and are referred to as hydatids of Morgagni. These cysts, lined by benign serous tubal-type epithelium, are presumed to arise in remnants of the Mullerian duct and are of little significance. Benign tumors of the fallopian tube are rare and include adenomatoid tumor, mesothelioma, which occurs subserosally on the tube or sometimes in the mesosalpinx. These small nodules are counterparts of the adenomatoid tumors that occur in the testes or epididymis. Chapter 21. Historically, fallopian tube carcinoma was considered to be a rare entity. However, substantial data have accumulated indicating that at least a subset of serous ovarian cancers actually arise from the epithelium of the fallopian tube discussed later. This idea is supported by the frequent identification of serous tubal in situ carcinoma in women at risk for serous carcinoma, e.g., women with germline BRCA mutations, and observations showing that failure to remove the fallopian tubes at the time of oophorectomy is associated with a significant residual risk of ovarian cancer. We will return to this issue when discussing ovarian cancer in the next section. Ovaries. The most common lesions encountered in the ovary are functional or benign cysts and tumors. Neoplastic disorders can be grouped according to their origin from each of the 3 main ovarian cell types: 1 Müllerian epithelium, 2 germ cells, and 3 sex cord stromal cells. Primary inflammations of the ovary oophoreitis are uncommon, and on rare occasions may have an autoimmune basis, autoimmune oophoreitis. The autoimmune reactions affect the ovarian follicles and may lead to infertility. Non-neoplastic and functional cysts. Follicle and luteal cysts. Cystic follicles are very common in the ovary. They originate from unruptured Graafian follicles or in follicles that have ruptured and immediately sealed. Morphology. These cysts are usually multiple. They range in size up to 2 centimeters in diameter, are filled with a clear serous fluid, and are lined by a gray, glistening membrane. On occasion, larger cysts exceeding 2 centimeters, follicle cysts, may be diagnosed by palpation or ultrasonography. These may cause pelvic pain. Granulosa lining cells are present if the intraluminal pressure has not been so great as to cause their atrophy. The outer theca cells may be conspicuous due to increased amounts of pale cytoplasm, a change referred to as luteinization. As discussed later, when luteinization is pronounced hyperthecosis, it may be associated with increased estrogen production and endometrial abnormalities. Luteal cysts, corpora lutea, are present in the normal ovaries of women of reproductive age. They are lined by a rim of bright yellow tissue containing luteinized granulosa cells and are prone to rupture, which may produce a peritoneal reaction. Sometimes the combination of old hemorrhage and fibrosis may make their distinction from endometriotic cysts difficult. Polycystic ovaries and stromal hyperthecosis. Polycystic ovarian syndrome, PCOS, is a complex endocrine disorder characterized by hyperandrogenism, menstrual abnormalities, polycystic ovaries, chronic anovulation, and decreased fertility. Formerly called Stein-Leventhal syndrome, it affects 6% to 10% of reproductive age women worldwide. It is also associated with obesity, type 2 diabetes, and premature atherosclerosis, all of which may be indicative of an underlying metabolic disorder. The etiology of PCOS remains incompletely understood. It is marked by a dysregulation of enzymes involved in androgen biosynthesis and excessive androgen production, which is considered to be a central feature of this disorder. In addition, women with PCOS show insulin resistance and altered adipose tissue metabolism, which contribute to the development of both diabetes and obesity. The central morphologic abnormality of PCOS is numerous cystic follicles, or follicle cysts, that enlarge the ovaries. However, polycystic ovaries are detected in 20% to 30% of all women, so this finding is not specific. In addition, due to an increase in free serum estrone levels, women with PCOS are at risk for endometrial hyperplasia and carcinoma. Stromal hyperthecosis, also called cortical stromal hyperplasia, is a disorder of ovarian stroma most often seen in postmenopausal women, but it may overlap with PCOS in younger women. The disorder is characterized by uniform, usually bilateral, enlargement of the ovary up to 7 centimeters, which has a white to tan appearance on sectioning. Microscopic examination shows hypercellular stroma and luteinization of the stromal cells, which are visible as discrete nests of cells with vacuolated cytoplasm. The clinical presentation and effects on the endometrium are similar to those of PCOS, although viralization may be even more striking. A physiologic condition mimicking the aforementioned syndromes is theca lutein hyperplasia of pregnancy. In response to pregnancy hormones, gonadotropins, theca cells proliferate and the parafollicular zone expands. As the follicles regress, the concentric theca lutein hyperplasia may appear nodular. This change is not to be confused with true luteomas of pregnancy. See later. Ovarian tumors. There are numerous types of ovarian tumors. About 80% are benign, and these occur mostly in young women between 20 and 45 years of age. So-called borderline tumors. Tumors, ovaries 1017, of indeterminate malignancy, occur at slightly older ages. Malignant tumors are more common in women between 45 and 65 years of age. Ovarian cancer accounts for 3% of all cancers in females and is the 5th most common cause of death due to cancer in women in the United States. Because most ovarian cancers have spread beyond the ovary and fallopian tube by the time of diagnosis, they account for a disproportionate number of deaths from cancer of the female genital tract. Classification. The classification of ovarian tumors given in Table 22.5 is a simplified version of the World Health Organization histological classification, which separates ovarian neoplasms according to the most probable tissue of origin. It is now believed that most tumors of the ovary arise ultimately from one of 3 ovarian components. 22. Who classification of ovarian neoplasms. Surface epithelial stromal tumors, serous tumors, benign cystadenomas, cystadenophibroma, borderline serous borderline tumor, malignant low and high-grade serous adenocarcinoma mucinous tumors, endocervical-like and intestinal type. Benign cystadenoma, cystadenophibroma, borderline mucinous borderline tumor, malignant mucinous adenocarcinoma endometrioid tumors. Benign cystadenoma, cystadenophibroma, borderline endometrioid borderline tumor, malignant endometrioid adenocarcinoma clear cell tumors. Benign borderline malignant clear cell adenocarcinoma transitional cell tumors. Benign Brenner tumor. Brenner tumor of borderline malignancy. Malignant Brenner tumor epithelial stromal. Adenosarcoma malignant mixed Müllerian tumor. Sex cord stromal tumors. Granulosa tumors fibromas. Fibrothocomas Thocomas Sertoli Leydig cell tumors steroid lipid cell tumors. Germ cell tumors. Teratoma. Immature mature solid cystic dermoid cyst monodermal e.g. struma ovari. Carcinoid dysgerminoma yolk sac tumor mixed germ cell tumors. Metastatic cancer from non-ovarian primary, colonic, appendiceal gastric pancreaticobiliary breast of major ovarian tumors. Percentage of malignant type ovarian tumors. Serous. Benign 60% 25, borderline 15% 47-30, malignant 25% 65, mucinous benign 80% 5, borderline 10%, 3-10 malignant 10% less than 5, endometrioid carcinoma 20-40. Undifferentiated carcinoma 10, clear cell carcinoma 6-40, granulosa cell tumor 5-5, teratoma 15, benign 96%, 1 rare malignant metastatic 5, greater than 50, others 3, frequency. Table 22.6. Surface fallopian tube epithelium and endometriosis. Germ cells, which migrate to the ovary from the yolk sac and are pluripotent. Stromal cells, including the sex cords, which are forerunners of the endocrine apparatus of the postnatal ovary. There is also a group of miscellaneous tumors, and finally, there are secondary or metastatic tumors to the ovary. Although some of the specific tumors have distinctive features and are hormonally active, most are non-functional and produce few symptoms until they reach a large size. Some, principally epithelial tumors, are often bilateral. Table 22.6 lists the tumors and their subtypes. Abdominal pain and distension, urinary and gastrointestinal tract symptoms due to compression by the tumor or cancer invasion, and vaginal bleeding are the most common symptoms. The benign forms may be entirely asymptomatic and occasionally are found unexpectedly on abdominal or pelvic examination or during surgery. Epithelial tumors. Most primary ovarian neoplasms arise from Müllerian epithelium. The classification of these tumors is based on both differentiation and extent of proliferation of the epithelium. There are 3 major histologic types based on the differentiation of the neoplastic epithelium: serous, mucinous, and endometrioid tumors. These epithelial proliferations are classified as benign, borderline, and malignant. The benign tumors are often further subclassified based on the components of the tumors, which may include cystic areas cystadenoma, cystic and fibrous areas cystadenophibroma, and predominantly fibrous areas adenofibroma. The borderline tumors and the malignant tumors can also have a cystic component, and when malignant, they are sometimes referred to as cystadenocarcinoma. The tumors can be relatively small, or they can grow to fill the entire pelvis before they are detected. Percentage that are bilateral. 1018. Chapter 22, the female genital tract. Cystadenoma, endometriosis, borderline tumor, type Y, low-grade serous endometrioid mucinous, inclusion, cyst, fallopian tube, fimbriae, stick, type 2, high-grade serous. Figure. Schematic diagram of the pathogenesis of ovarian epithelial tumors. Type 1 tumors progress from benign tumors through borderline tumors that may give rise to a low-grade carcinoma. These include low-grade serous, endometrioid, and mucinous carcinomas. Type 2 tumors arise from inclusion cysts, fallopian tube epithelium via intraepithelial precursors that are often not identified. They demonstrate high-grade features and are most commonly of serous histology. Stick, serous tubal intraepithelial carcinoma. Clinical pathologic and molecular studies have suggested that ovarian carcinoma may be broadly categorized into 2 different types, referred to as type 1 and type 2, figure 22:30. Type 1 carcinomas are low-grade tumors that often arise in association with borderline tumors or endometriosis. These tumors encompass several histologic subtypes, including low-grade serous, endometrioid, and mucinous tumors, as discussed later. Type 2 tumors are most often high-grade serous carcinomas that arise from serous intraepithelial carcinoma, see later. Serous tumors. These cystic neoplasms include the most common malignant ovarian tumors and account for approximately 40% of all cancers of the ovary. Although the term serous appropriately describes the cyst fluid, it has become synonymous with the tubal-like epithelium in these tumors. Together, benign, borderline, and malignant serous tumors account for about 30% of all ovarian tumors and just over 50% of ovarian epithelial tumors. About 70% are benign or borderline, and 30% are malignant. Benign and borderline tumors are most common between 20 and 45 years of age. Serous carcinomas occur later in life on average, but often occur at earlier ages in familial cases. Pathogenesis little is known about the risk factors for benign and borderline tumors. Risk factors for malignant serous tumors, serous carcinomas, are also not completely understood, but nulliparity, family history, and heritable mutations play a role in tumor development. There is a higher frequency of carcinoma in women with low parity, women 40 to 59 years of age who have taken oral contraceptives or undergone tubal ligation have a reduced risk of developing ovarian cancer. The most intriguing risk factors are genetic. As discussed in chapters 7 and 23, inherited germline mutations in both BRCA1 and BRCA2 increase susceptibility to both ovarian cancer and breast cancer. 1 mutations are present in about 5% of patients younger than 70 years of age with ovarian cancer. The estimated risk of ovarian cancer in women bearing BRCA1 or BRCA2 mutations is 20% to 60% by 70 years of age. Serous ovarian carcinoma is divided into 2 major groups, low-grade carcinoma and high-grade carcinoma. This distinction is made based on the degree of nuclear atypia and correlates with patient survival. Low-grade carcinomas may arise in association with serous borderline tumors, while high-grade carcinomas arise from in situ lesions in the fallopian tube fimbriae, or from serous inclusion cysts within the ovary. The concept of a fallopian tube origin for high-grade serous carcinomas was initially sparked by the observation that women with BRCA1, 2 germline mutations were often discovered at the time of prophylactic salpingo-oophorectomy to have areas of marked epithelial atypia in their fallopian tubes. The lesions, called serous tubal intraepithelial carcinoma STIC, have since been described in association with sporadic high-grade serous ovarian cancers, suggesting that at least some high-grade serous carcinomas arise from the fallopian tube. What then is the origin of high-grade serous carcinomas that involve the ovary without concomitant involvement of the fallopian tube? Historically, the source of these tumors was hypothesized to be cortical inclusion cysts, figure 22-31, which were thought to arise through invagination of the surface epithelium, followed by serous metaplasia. A recent alternative idea is that the cysts arise from implantation of detached fallopian tube epithelium at sites where ovulation has disrupted the surface of the ovary, see figure 22-30. The percentage of sporadic high-grade serous carcinomas that arise in the fallopian tube or from ovarian inclusion cysts is currently uncertain, as is the origin of cortical inclusion cysts. However, this paradigm shift has already altered the management of women at high risk for ovarian. Figure 22.3, 1 cortical inclusion cysts of the ovary, 1019. Carcinoma BRCA mutation carriers in women with a strong family history of breast ovarian cancer, as these women now undergo salpingo-oophorectomy instead of simple oophorectomy. Regardless of their origin, studies have shown that low and high-grade serous carcinoma have distinct mutational profiles as follows. Low-grade tumors arising in serous borderline tumors have mutations in the KRAS, BRAF, or ERBB2 oncogenes, and usually have wild-type TP53 genes. High-grade tumors have a high frequency of TP53 mutations and lack mutations in either KRAS or BOF. Genomic imbalances are very common and include amplifications of a number of oncogenes, e.g. PIK3CA, the gene encoding the catalytic subunit of PI3K, and deletions of tumor suppressor genes, e.g. RNB. Almost all ovarian carcinomas arising in women with BRCA1 or BRCA2 mutations are high-grade serous carcinomas with TP53 mutations. Curiously, BRCA1 and BRCA2 mutations are rare in sporadic high-grade serous carcinoma. Of the stroma is not seen, figure 22-33b. The epithelial cells often grow in a delicate papillary pattern referred to as micropapillary carcinoma, which is thought to be the precursor to low-grade serous carcinoma. Figure 22-33c. High-grade serous carcinoma is distinguished by having more complex growth patterns and widespread infiltration or frank effacement of the underlying stroma. Figure 22-33d. The individual tumor cells display marked nuclear atypia, including pleomorphism, atypical mitotic figures, and multinucleation occasionally. Tumors may be so undifferentiated that serous features are no longer recognizable. Serous tubal intraepithelial carcinoma consists of cells morphologically identical to high-grade serous carcinoma that do not invade the underlying stroma. Concentric calcifications, psammoma bodies, are common in all types of serous tumors, but are not specific for neoplasia. Ovarian serous tumors, both low and high grade, have a propensity to spread to the peritoneal surfaces and omentum, and are commonly associated with the presence of ascites. As with other tumors, the extent of the spread outside the ovary determines the stage of the disease. Ovaries, morphology. Serous tumors may present as a multicystic lesion, in which papillary epithelium is contained within fibrous-walled cysts, intracystic, figure 22-32a, or as a mass projecting from the ovarian surface. Benign tumors typically have a smooth, glistening cyst wall with no epithelial thickening or with small papillary projections. Borderline tumors contain an increased number of papillary projections, figure 22, 32a and c. Larger areas of solid or papillary tumor growth, tumor irregularity, and fixation or nodularity of the capsule are features associated with malignancy, figure 22, 32b. Bilaterality is common, occurring in 20% of benign serous cystadenomas, 30% of serous borderline tumors, and approximately 66% of serous carcinomas. A significant proportion of borderline and malignant serous tumors involve the surface of the ovary, figure 22, 32c. Microscopically, the cysts are lined by columnar epithelium. In benign tumors, figure 22, 33a, the epithelial cells retain abundant cilia and microscopic papillae may be found. Serous borderline tumors exhibit increased complexity of the stromal papillae, stratification of the epithelium, and mild nuclear atypia, but invasion. The biologic behavior of serous tumors depends on the degree of differentiation and the extent and distribution of peritoneal disease. Serous tumors may occur on the surface of the ovaries. If unencapsulated, such tumors are likely to spread to the peritoneum. As discussed, at least some of these carcinomas likely originate from the fallopian tube, from which they may exfoliate and spread to the peritoneum. In rare instances, they appear to originate on the peritoneal surface, referred to as primary peritoneal serous carcinoma. Prognosis is closely related to the histologic appearance of the tumor and the presence and extent of peritoneal disease. Borderline serous tumors may arise from or secondarily involve the peritoneal surfaces as non-invasive implants, remaining localized and causing no symptoms or slowly spread, producing intestinal obstruction or other complications after many years. Similarly, low-grade carcinomas, even after spread outside the ovary, often progress slowly, and patients may survive for relatively long periods before dying of disease. In contrast, high-grade tumors are often widely metastatic throughout the abdomen at the time. ABC figure 22.32 gross appearances of serous tumors of the ovary. A. Serous borderline tumor open to display a cyst cavity lined by delicate papillary tumor growths. B. Carcinoma. The cyst is open to reveal a large, bulky tumor mass. C. Another borderline tumor growing on the ovarian surface, lower. Chapter 22, the female genital tract. A B, CD figure, 22.3. 3 microscopic appearances of serous tumors of the ovary. A. Serous cystadenoma, revealing stromal papillae with a columnar epithelium. B. Borderline serous tumor showing increased architectural complexity and epithelial cell stratification. C. Complex micropapillary growth defines a low-grade micropapillary serous carcinoma. D. High-grade serous carcinoma of the ovary with invasion of underlying of presentation, a picture associated with rapid clinical deterioration. Consequently, grading of the tumor, even after extension to the peritoneum, impacts both prognosis and selection of therapy. The 5-year survival rate for borderline and malignant tumors confined to the ovary is 100% and 70%, respectively, whereas the 5-year survival rate for the same tumors involving the peritoneum is about 90% and 25%, respectively. Because of their protracted course, borderline tumors may recur after many years, and 5-year survival is not synonymous with cure. Mucinous tumors. Mucinous tumors account for about 20% to 25% of all ovarian neoplasms. They occur principally in middle adult life and are rare before puberty and after menopause. The vast majority are benign or borderline tumors. Primary ovarian mucinous carcinomas are uncommon and account for approximately 3% of all ovarian cancers. Pathogenesis mutation of the KRAS proto-oncogene is a consistent genetic alteration in mucinous tumors of the ovary, including the majority of benign mucinous cystadomases, mucinous borderline tumors, 75% to 86%, and ovarian mucinous carcinomas, 85%. Interestingly, one study showed that several tumors with distinct areas of epithelium showing benign, borderline, and carcinoma had identical KRAS mutations in each area. Thus, KRAS mutations may initiate the development of these neoplasms. Morphology: mucinous tumors differ from the serous variety in several ways. The surface of the ovary is rarely involved, and only 5% of primary mucinous cystadenomas and mucinous carcinomas are bilateral. Mucinous tumors also tend to produce larger cystic masses. Some have been recorded with weights of more than 25 kilograms. They are multiloculated tumors filled with sticky, gelatinous fluid rich in glycoproteins, figure 2234a. Microscopically, benign mucinous tumors are characterized by a lining of tall, columnar epithelial cells with apical mucin that lack cilia. The vast majority demonstrate gastric or intestinal type differentiation. Uncommonly, tumors may show endocervical type mucinous differentiation instead. Figure 20. Mucinous borderline tumors are distinguished from cystadenomas by epithelial stratification, tufting, erupting, and/or papillary intraglandular growth, often producing an appearance strikingly similar to tubular adenomas or villous adenomas of the intestine. Mucinous carcinoma characteristically demonstrates confluent glandular growth that is now recognized as a form of expansial invasion. Some authors use the term intraepithelial carcinomas for tumors with marked epithelial atypia that lack invasive features. Approximate 10-year survival rates for stage I non-invasive intraepithelial carcinoma and for frankly invasive malignant tumors are greater than 95% and 90% respectively. Mucinous carcinomas that have spread beyond the ovary are usually fatal, but as stated earlier, these tumors are uncommon and must be distinguished from metastatic mucinous adenocarcinomas, 1020. Ovaries, 1021. A B, figure 22.3. 4 mucinous cystadenoma. Note, the multicystic appearance, delicate septa, and the presence of glistening mucin within the cysts. B. Columnar cells lining the cysts, a clinical condition referred to as pseudomyxoma peritoni, is marked by mucinous ascites, cystic epithelial implants on the peritoneal surfaces, adhesions, and frequent involvement of the ovaries. Figure 22.35. Pseudomyxoma peritoni, if extensive, may result in intestinal obstruction and death. Historically, it was thought that many cases in women were due to the spread of primary ovarian mucinous neoplasms. However, recent evidence points in almost all cases to an extra ovarian source, usually the appendix chapter 17. Because the majority of primary mucinous ovarian tumors are unilateral, bilateral presentation of mucinous tumors always requires exclusion of metastasis from a non-ovarian primary tumor. Endometrioid ovarian tumors. Endometrioid carcinoma accounts for approximately 10% to 15% of all ovarian cancers. Benign endometrioid tumors, called endometrioid adenofibroma, and borderline endometrioid tumors also occur but are uncommon. Approximately 15% to 30% of ovarian endometrioid carcinomas are accompanied by carcinoma of the endometrium. Although such cases have a relatively good prognosis, molecular data suggest that in most instances of concomitant endometrial and ovarian disease, the ovarian disease arises from metastatic spread of a primary endometrial tumor. Pathogenesis in about 15% to 20% of cases, endometrioid carcinoma coexists with endometriosis. The peak incidence of tumors associated with endometriosis is a decade earlier than that of endometrioid carcinomas that are not associated, suggesting that ovarian endometriosis serves as a precursor to ovarian endometrioid carcinoma in some instances. Molecular studies have found striking similarities to endometrioid carcinoma. Shared features include relatively frequent alterations that increase PI3K, ATT pathway signaling, mutations in PTEN, PIK3CA, ARID1A, and crosses and mutations in mismatched DNA repair genes. Also similar to endometrioid carcinomas of the endometrium, TP53 mutations are common in poorly differentiated tumors. Morphology. Endometrioid tumors are distinguished from serous and mucinous tumors by the presence of tubular glands resembling benign or malignant endometrium. Endometrioid carcinomas, typically present with solid and cystic areas of growth, 40% involve both ovaries, and such bilaterality usually implies extension of the neoplasm beyond the genital tract. These are low-grade tumors that reveal glandular patterns bearing a strong resemblance to those of endometrial origin. The 5-year survival rate for patients with stage 1 tumors is approximately 75%. A B. Figure 22.3, 5 pseudomyxoma peritoni. A. View at laparotomy revealing massive overgrowth of a gelatinous metastatic tumor. B. Histology of peritoneal implants from an appendiceal tumor showing mucin-producing epithelium and free mucin arrow. A. Courtesy Dr. Paul H. Sugarbaker, Washington Hospital Cancer Center, Washington, D.C. Clear cell carcinoma benign and borderline clear cell tumors are exceedingly rare, and clear cell carcinomas are uncommon. They are composed of large epithelial cells with abundant clear cytoplasm, an appearance that resembles hypersecretory. Chapter 22, the female genital tract. Gestational endometrium. Because these tumors sometimes occur in association with endometriosis or endometrioid carcinoma of the ovary and resemble clear cell carcinoma of the endometrium, they are now thought to be variants of endometrioid adenocarcinoma. In line with this idea, the most common genetic aberrations, PIK3CA, ARID1A, KRAS, PTEN, and TP53, are shared with endometrioid carcinoma, albeit at somewhat different frequencies. Clear cell tumors of the ovary can be predominantly solid or cystic. In the solid neoplasms, the clear cells are arranged in sheets or tubules, while in the cystic variety, the neoplastic cells line the spaces. Clear cell carcinoma confined to the ovaries has a 90% 5-year survival, but in advanced stage disease it appears that clear cell morphology portends a poor outcome. Clear cell carcinoma is treated like other types of ovarian carcinoma, cystadenofibroma, Cystadenofibroma is an uncommon variant in which there is pronounced proliferation of the fibrous stroma that underlies the columnar lining epithelium. These benign tumors are usually small and multilocular and have simple papillary processes that are not as complicated and branching as those found in the ordinary cystadenoma. They may contain mucinous, serous, endometrioid, or transitional Brenner tumor epithelium. Borderline lesions with cellular atypia and rarely tumors with focal areas of carcinoma occur, but metastatic spread of either is extremely uncommon. Transitional cell tumors. Transitional cell tumors contain neoplastic epithelial cells resembling urothelium and are usually benign. They comprise roughly 10% of ovarian epithelial tumors and are also referred to as Brenner tumors. Uncommon transitional cell carcinomas also occur in the ovary. Morphology. Brenner tumors may be solid or cystic, are usually unilateral approximately, and vary in size from small lesions less than 1 centimeter in diameter to massive tumors up to 20 to 30 centimeters in diameter. Figure 22-36a. The fibrous stroma, resembling that of the normal ovary, is marked by sharply demarcated nests of epithelial cells resembling the epithelium of the urinary tract, often with mucinous glands in their center. Figure 22-36b. Infrequently, the stroma is composed of plump fibroblasts resembling theca cells. Such neoplasms may have hormonal activity. Most Brenner tumors are benign, but borderline and malignant counterparts have been reported. Tumors with benign Brenner nests admixed with malignant tumor cells are referred to as malignant Brenner tumors, while tumors with greater than 50% malignant transitional type epithelium are considered transitional cell carcinomas of the ovary. 1022. Brenner tumors are often detected incidentally, and even when large, behave in a benign fashion. Malignant Brenner tumors generally present in stage 1 and for prognostic purposes are considered to be equivalent to low-grade, type 1, carcinomas. The uncommon transitional cell carcinomas are considered to be equivalent to high-grade, type 2 ovarian carcinomas. These often present at advanced stage and are treated like high-grade serous carcinoma. Clinical course, detection and prevention of ovarian epithelial tumors. All ovarian carcinomas produce similar clinical manifestations, most commonly lower abdominal pain and abdominal enlargement. Gastrointestinal complaints, urinary frequency, dysuria, pelvic pressure, and many other symptoms may appear. Benign lesions are easily resected and cured. The malignant tumors tend to cause progressive weakness, weight loss, and cachexia. Once carcinomas extend through the capsule of the tumor and seed the peritoneal cavity, they often cause ascites, which may be massive. Characteristically, the acidic fluid is filled with exfoliated tumor cells. The peritoneal pattern of spread is distinctive. Serosal surfaces are diffusely seeded with 0.1 to 0.5 cm nodules of tumor that only rarely invade deeply into the underlying parenchyma. The regional nodes are often involved, and metastases may be found in the liver, lungs, gastrointestinal tract, and elsewhere. Metastasis across the midline to the opposite ovary is discovered in about 1/2 the cases at surgery and heralds a progressive downhill course and death within a few months or years. A B figure 22.36 Brenner tumor, A Brenner tumor right, associated with a benign cystic teratoma left, B. Histologic detail of characteristic epithelial nests within the ovarian stroma. Courtesy Dr. M. Nucci, Brigham and Women's Hospital, Boston, Mass. Ovaries 1023. Most women with ovarian carcinoma present with high-stage disease. This is the primary reason for the relatively poor 5 and 10-year survival rates of patients with these tumors, as compared with rates for patients with cervical or endometrial carcinoma. For these reasons, development of new assays that permit early diagnosis is a top priority. Biochemical tests for tumor antigens or tumor products in the plasma of these patients are being sought vigorously, but none proposed to date has sufficient sensitivity and specificity to be used. The serum marker CA-125 is used in patients with known disease to monitor disease recurrence progression. Prevention of ovarian cancer also remains an elusive goal. Screening to identify women at risk positive for BRCA mutations or with strong family histories, and treatment with risk-reducing salpingo-oophorectomy are currently standard. The long-term impact of these approaches in women at high risk remains to be determined. Recent data suggest that there remains a 3% to 4% risk of developing ovarian cancer after salpingo-oophorectomy. Key concepts. Epithelial ovarian tumors are classified into benign, borderline, or malignant. About 80% of all ovarian epithelial tumors are benign and occur in young women. The malignant tumors occur most commonly in older women and account for approximately 3% of all cancers in women in the United States. The majority of the malignant epithelial tumors are high-grade serous carcinomas, which have a poor prognosis in large part because they are usually detected after they have spread beyond the ovary and/or the fallopian tube. There are 3 major histologic types of epithelial ovarian tumors, serous, mucinous, and endometrioid, all of which have a benign, borderline, and malignant category. Benign tumors are composed of well-differentiated epithelial cells with minimal proliferation. Borderline tumors show increased cell proliferation but lack stromal invasion. Malignant tumors show increased epithelial atypia and are defined by the presence of stromal invasion. Ovarian carcinomas are currently divided into type 1 low-grade and type 2 high-grade tumors. The origin of ovarian tumors is still under investigation, but it appears that BRCA1 and BRCA2 related tumors, as well as the majority of sporadic ovarian serous tumors, likely arise from fallopian tube epithelium rather than ovarian epithelium. Dysgerminoma. Yolk sac tumor, germ cell, extraembryonic structures. Figure 22.3. 7 histogenesis and interrelationships of ovarian tumors of germ cell origin. Mature benign teratomas. Most benign teratomas are cystic and are often referred to as dermoid cysts because they are almost always lined by skin-like structures. Cystic teratomas are usually found in young women. They may be discovered incidentally, but are occasionally associated with clinically important paraneoplastic syndromes, such as inflammatory limbic encephalitis, which may remit following removal of the tumor. Morphology. Benign teratoma is bilateral in 10% to 15% of cases. Characteristically, it consists of a unilocular cyst containing hair and sebaceous material. Figure 22. Sectioning reveals a thin wall lined by opaque, gray-white, wrinkled epidermis, frequently with protruding hair shafts. Within the wall, it is common to find grossly evident tooth structures and areas of calcification. Microscopically, the cyst wall is composed of stratified squamous epithelium with underlying sebaceous glands, hair shafts, and other skin adnexal structures. Figure 22.39. In most cases, tissues from other germ layers can be identified, such as cartilage, bone, thyroid, and neural tissue. Dermoid cysts are sometimes incorporated within the wall of a mucinous cystadenoma. About 1% of the embryonal carcinoma, non-gestational choriocarcinoma, embryonic structures. Teratoma, mature immature. Germ cell tumors. Germ cell tumors constitute 15% to 20% of all ovarian tumors and include multiple subtypes. Most are benign cystic teratomas, but others, found principally in children and young adults, may show malignant behavior and pose problems in histologic diagnosis and in therapy. They bear a high degree of morphologic and molecular similarity to germ cell tumors in the male testis. Chapter 21. Teratoma. Teratomas are divided into 3 categories: 1 mature benign, 2 immature malignant, and 3 monodermal or highly specialized. Figure 22.38. Open mature cystic teratoma dermoid cyst of the ovary. Hair bottom and a mixture of tissues are evident. Chapter 22. The female genital tract. Immature fetal tissue. The tumor is found chiefly in prepubertal adolescents and young women, the mean age being 18 years. Morphology. Figure 22.39. Benign cystic teratoma. Low power view of skin, right edge, beneath which there is brain tissue, left edge. Dermoid cysts undergo malignant transformation, most commonly to squamous cell carcinoma, but also to other cancers, e.g., thyroid carcinoma, melanoma. In rare instances, a benign teratoma is solid and composed entirely of benign-looking heterogeneous collections of tissues and organized structures derived from all 3 germ layers. These tumors presumably have the same histogenetic origin as dermoid cysts but lack preponderant differentiation into ectodermal derivatives. Such neoplasms may be difficult to distinguish from malignant immature teratomas on gross inspection. The origin of teratomas has been a matter of fascination for centuries. Some common beliefs blamed witches, nightmares, or adultery with the devil. The karyotype of almost all benign ovarian teratomas is 46XX. Genetic analyses indicate that the majority of teratomas arise from an ovum after the first meiotic division, while the remainder arise before the first division. Monodermal or specialized teratomas are a rare but remarkable group of tumors, the most common of which are struma ovarii and carcinoid. They are always unilateral, although a contralateral teratoma may be present. Struma ovarii is composed entirely of mature thyroid tissue, which may be functional and cause hyperthyroidism. Carcinoid tumors, which presumably arise from intestinal tissue found in teratomas, may also be functional, particularly if large, greater than 7 centimeters. They can produce sufficient 5-hydroxytryptamine to cause the carcinoid syndrome, even in the absence of hepatic metastases, because ovarian veins connect directly to the systemic circulation. Primary ovarian carcinoid must be distinguished from metastatic intestinal carcinoid, which virtually always involves the ovaries bilaterally, Even rarer is stromal carcinoid, a combination of stroma ovariae and carcinoid in the same ovary. Only about 2% of carcinoids in teratomas metastasize, immature malignant teratomas. These are rare tumors that differ from benign teratomas in that the component tissues resemble embryonal, and immature malignant teratomas are bulky, have a smooth external surface, and tend to be solid on sectioning. Hair, sebaceous material, cartilage, bone, and calcification may be present, along with areas of necrosis and hemorrhage. On microscopic examination, there are varying amounts of immature neuroepithelium, cartilage, bone, muscle, and other elements. An important risk for subsequent extraovarian spread is the histologic grade I to II of the tumor. Grading is based on the proportion of the tumor that is comprised of immature neuroepithelium, figure 22:40. Immature teratomas grow rapidly, frequently penetrate the capsule, and spread either locally or distantly. Stage 1 tumors, particularly those with low-grade grade 1 histology, have an excellent prognosis. Higher-grade tumors confined to the ovary are generally treated with adjuvant chemotherapy. Most recurrences develop in the first 2 years, and absence of disease beyond this period carries an excellent chance of cure. Discarminoma. Discarminoma is the ovarian counterpart of testicular seminoma. Discarminoma accounts for about 2% of ovarian cancers, and roughly 50% of malignant ovarian germ cell tumors. They may occur in childhood, but 75% occur in the second and third decades of life. Some occur in patients with gonadal dysgenesis, including pseudohermaphroditism. Most of these tumors have no endocrine function. A few produce elevated levels of chorionic gonadotropin, a finding that correlates with the presence of syncytiotrophoblastic giant cells. Like seminoma, discarminoma expresses stem cell markers such as OxyT3, OxY4, and NANOG, transcription factors implicated in maintenance of pluripotency. They also express the receptor tyrosine kinase KIT, and approximately 1/3 have activating mutations in the KIT gene. These proteins are useful diagnostic markers and mutated. Figure 22.40 immature teratoma of the ovary illustrating primitive neuroepithelium. 1025. Constitutively active KIT also represents a potential therapeutic target. Morphology. Most discarminomas, 80% to 90%, are unilateral tumors ranging in size from barely visible nodules to masses that virtually fill the abdomen. On cut surface, they have a solid yellow-white to gray-pink appearance and are often soft and fleshy. Like seminoma, it is composed of large vesicular cells with clear cytoplasm, well-defined cell boundaries, and centrally placed regular nuclei. The tumor cells grow in sheets or cords separated by scant fibrous stroma, figure 22:41, which is infiltrated by lymphocytes and may contain non-caseating granulomas. On occasion, small nodules of discarminoma are encountered in the wall of an otherwise benign cystic teratoma. Conversely, a predominantly discarminomatous tumor may contain a small cystic teratoma. Figure 22.42, a Schiller-Duval body in a yolk sac carcinoma. All discarminomas are malignant, but the degree of histologic atypia is variable, and only about 1/3 are aggressive. A unilateral tumor that has not broken through the capsule or spread outside the ovary has an excellent prognosis, up to 96% cure rate after simple salpingoophorectomy. These neoplasms are responsive to chemotherapy, and even those that have extended beyond the ovary can often be cured. Overall survival exceeds 80%. Yolk sac tumors, though rare, yolk sac tumor, also known as endodermal sinus tumor, still ranks as the second most common malignant ovarian tumor of germ cell origin. It is thought to be derived from malignant germ cells that are differentiating along the extraembryonic yolk sac lineage, see figure 22:37. Similar to the normal yolk sac, the tumor cells elaborate alpha-fetoprotein. Its characteristic histologic feature is a glomerulus-like structure composed of a central blood vessel enveloped by tumor cells within a space that is also lined by tumor cells, Schiller-Duval body. Figure 22:42. Conspicuous intracellular and extracellular hyaline droplets are typically present, some of which stain for alpha-fetoprotein by immunoperoxidase techniques. Most patients are children or young women presenting with abdominal pain and a rapidly growing pelvic mass that involves a single ovary. With combination chemotherapy, there is greater than 80% survival, independent of disease stage. Choriocarcinoma, more commonly of placental origin, ovarian choriocarcinoma, like yolk sac tumor, is an example of a malignant germ cell that exhibits extraembryonic differentiation. Most ovarian choriocarcinomas exist in combination with other germ cell tumors, and pure choriocarcinoma is extremely rare. They are histologically identical to the more common placental lesions described later. The ovarian tumors are aggressive and have usually metastasized hematogenously to the lungs, liver, bone, and other sites by the time of diagnosis. Like all choriocarcinomas, they elaborate high levels of chorionic gonadotropins, which may be helpful in establishing the diagnosis or detecting recurrences. In contrast to choriocarcinoma arising in placental tissue, those arising in the ovary are generally unresponsive to chemotherapy and are often fatal. Other germ cell tumors, these include 1. Embryonal carcinoma, a highly malignant tumor of primitive embryonal elements that is histologically similar to embryonal carcinoma, arising in the testes, Chapter 21. 2. Polyembryoma, a malignant tumor containing so-called embryoid bodies. And 3. Mixed germ cell tumors containing various combinations of dysgerminoma, teratoma, yolk sac tumor, and choriocarcinoma. Key concepts: germ cell tumors. Germ cell tumors constitute 15% to 20% of ovarian tumors. The majority are mature cystic teratomas, dermoid cysts, in women of reproductive age. The remainder occur in young women and children. In these age groups, malignant tumors dominate. Ovaries. Figure 22.4. 1 dysgerminoma showing polyhedral tumor cells with round nuclei and adjacent inflammation. 1026, Chapter 22, the female genital tract. Immature teratomas are distinguished from mature teratomas by the presence of embryonal or fetal elements, most often consisting of primitive neuroepithelium. Germ cell tumors show various lines of differentiation toward oogonia, dysgerminoma, extraembryonic yolk sac, tumors, placenta, choriocarcinoma, or multiple germ layers. Teratoma. Grow in anastomosing cords, sheets, or strands. Figure 2243a. In occasional cases, small distinctive gland-like structures filled with an acidophilic material recall immature follicles, called Exner bodies. When these structures are evident, the diagnosis is straightforward. Occasionally, there is a predominant thecoma component that consists of clusters or sheets of cuboidal 2. Polygonal cells, see later. In some tumors, the granulosa or theca cells may appear plumper and have ample cytoplasm characteristic of luteinization, i.e., luteinized granulosa theca cell tumors. Sex cord stromal tumors. These ovarian neoplasms arise from the ovarian stroma, which is derived from the sex cords of the embryonic gonad. The undifferentiated gonadal mesenchyme eventually produces specific types of cells in male Sertoli and Leidig and female granulosa and theca gonads. And tumors resembling all of these cell types can be identified in the ovary. Moreover, because some of these cells normally secrete estrogens, granulosa and theca cells, or androgens, Leidig cells, their corresponding tumors may be either feminizing granulosa theca cell tumors or masculinizing Leidig cell tumors. Granulosa cell tumors. Granulosa cell tumors are composed of cells that resemble granulosa cells of a developing ovarian follicle. They are broadly divided into adult and juvenile granulosa cell tumors, based largely on the age of the patient. Collectively, these neoplasms account for about 5% of all ovarian tumors, and 95% of granulosa cell tumors are of the adult type. Although they may be discovered at any age, approximately 2/3 occur in postmenopausal women. Morphology. Granulosa cell tumors are usually unilateral and vary from microscopic foci to large, solid, and cystic encapsulated masses. Tumors that are hormonally active have a yellow coloration to their cut surfaces due to intracellular lipids. The granulosa cell component of these tumors has many histologic patterns. The small cuboidal to polygonal cells may. Granulosa cell tumors are of clinical importance for 2 reasons. 1, they sometimes elaborate large amounts of estrogen, and 2, they may behave like low-grade malignancies. Functionally active tumors in prepubertal girls, juvenile granulosa cell tumors, may produce precocious sexual development. In adult women, they may be associated with proliferative breast disease, endometrial hyperplasia, and endometrial carcinoma, which eventually develops in about 10% to 15% of women with steroid-producing tumors. Occasionally, granulosa cell tumors produce androgens, masculinizing the patient. All granulosa cell tumors are potentially malignant. It is difficult to predict their biologic behavior from histology. The likelihood of malignant behavior recurrence, extension, ranges from 5% to 25%. In general, malignant tumors pursue an indolent course in which local recurrences may be amenable to surgical therapy. Recurrences within the pelvis and abdomen may appear 10 to 20 years after removal of the original tumor. The 10-year survival rate is approximately 85%. Tumors composed predominantly of theca cells are almost never malignant. Elevated tissue and serum levels of inhibin, a product of granulosa cells, are associated with granulosa cell tumors. Detection and measurement of inhibin is useful in diagnosing granulosa and other sex cord, stromal tumors, see figure 2243b, and for monitoring patients being treated for these neoplasms. The most common driver mutations are found in the FOXL gene, which is mutated in of adult granulosa cell tumors. FOXL2 encodes a transcription factor that is important in granulosa cell development, which presumably explains its strong association with this tumor type. Interestingly, mutations in FOXL2 appear to be less. A B figure 22.43 granulosa cell tumor. A. Tumor cells are arranged in sheets punctuated by small follicle-like structures called Exner bodies. B. Strong immunohistochemical positivity with an antibody to inhibin characterizes these tumors. 1027. A B figure 22.44 ovarian fibroma. A. The coma fibroma composed of plump differentiated stromal cells with thiccal appearance. B. Large bisected fibroma of the ovary apparent as a white, firm mass, right. The fallopian tube is attached, common in juvenile granulosa tumor, suggesting that it is genetically distinct from the adult type. Fibromas, thecomas, and fibrothecomas tumors arising in the ovarian stroma that are composed of either fibroblasts fibromas or plump spindle cells with lipid droplets thecomas are relatively common, accounting for about 4% of all ovarian tumors. Figure 2244a. Many tumors contain a mixture of these cells and are termed fibrothecomas. Fibrothecomas and pure thecomas, a rare subtype, may be hormonally active. By contrast, pure fibromas as a rule are hormonally inactive. Fibromas of the ovary are unilateral in about 90% of cases and are usually solid, spherical, or slightly lobulated, encapsulated, hard gray-white masses covered by glistening, intact ovarian serosa. See figure. On histologic examination, they are composed of well-differentiated fibroblasts and scant interspersed collagenous stroma. Focal areas of thecal differentiation may be identified. Most of these tumors come to attention as a pelvic mass, sometimes accompanied by pain and two decidedly curious associations. The first is ascites, found in about 40% of cases in which the tumors measure more than 6 centimeters in diameter. Uncommonly, there is also a hydrothorax, usually only on the right side. This combination of findings, ovarian tumor, hydrothorax, and ascites, is designated Meigs syndrome. Its genesis is unknown. The second association is with the basal cell nevus syndrome, described in Chapter 25. The vast majority of fibromas, fibrothecomas, and thecomas are benign. Rarely, cellular fibromas with mitotic activity and increased nuclear to cytoplasmic ratio are identified because they may pursue a malignant course. They are termed fibrosarcomas. Sertoli-Leydig cell tumors. These tumors are often functional. They most commonly produce masculinization or defeminization, but a few have estrogenic effects. The tumor cells recapitulate, to a certain extent, testicular Sertoli or Leydig cells at various stages of development. They occur in women of all ages, although the peak incidence is in the second and third decades. In over one-half of cases, the tumor cells have mutations in dicer1, a gene that you will recall encodes an endonuclease that is essential for proper processing of microRNAs. The presence of dicer1 mutations suggests that genesis of these tumors involves abnormalities of gene expression related to dysregulation of microRNAs. Morphology. These tumors are unilateral and may resemble granulosa cell tumors grossly. The cut surface is usually solid and varies from gray to golden brown in appearance, figure 2245a. Microscopically, a B figure 22.45 Sertoli cell tumor. A. Gross photograph illustrating characteristic golden yellow appearance of the tumor. B. Photomicrograph showing well-differentiated Sertoli cell tubules. Courtesy Dr. William Welch, Brigham and Women's Hospital, Boston, Mass. Varies. Chapter 22. The female genital tract. Immature Sertoli and granulosa cells. It occurs in individuals with abnormal sexual development and in gonads of indeterminate nature. 80% of patients are phenotypic females, and 20% are phenotypic males with undescended testicles and female internal secondary organs. A coexistent dysgerminoma occurs in 50% of the cases. The prognosis is excellent if the tumor is completely excised. A range of differentiation is seen. Well-differentiated tumors show tubules composed of Sertoli cells, or Leydig cells, interspersed with stroma figure 2245b. The intermediate forms show only immature tubules and large eosinophilic Leydig cells. The poorly differentiated tumors have a sarcomatous pattern with a disorderly disposition of epithelial cell cords. Leydig cells may be absent. Heterologous elements such as mucinous glands, bone, and cartilage may be present in some tumors. The incidence of recurrence or metastasis by Sertoli Leydig cell tumors is less than 5%. These neoplasms may block normal female sexual development in children and may cause defeminization of women, manifest by atrophy of the breasts, amenorrhea, sterility, and loss of hair. The syndrome may progress to striking virilization, hirsutism, associated with male hair distribution, hypertrophy of the clitoris, and voice changes. Other sex cord, stromal tumors. There are several other uncommon but distinctive ovarian tumors of sex cord or stromal origin that often produce steroid hormones. Hyalus cell tumors. Pure Leydig cell tumors are rare unilateral tumors comprised of large, lipid-laden Leydig cells with distinct borders and characteristic cytoplasmic structures called rankicrystalloids. Women with Hyalus cell tumors usually present with evidence of masculinization, hirsutism, voice changes, and clitoral enlargement, but these changes are milder than those seen in association with Sertoli Leydig cell tumors. The tumors produce predominantly testosterone. Treatment consists of surgical excision. True Hyalus cell tumors are almost always benign. Pregnancy luteoma refers to a rare tumor that closely resembles the corpus luteum of pregnancy. These tumors may produce virilization in pregnant patients and their female infants. Gonadoblastoma is an uncommon tumor composed of germ cells and sex cord stroma derivatives resembling. Key concepts: sex cord stromal tumors. Granulosa cell tumors are the most common malignant tumor in this category. They are indolent tumors, but may recur 10 to 20 years after resection of the primary tumor. They are often hormonally active. Such tumors are associated with hyperestrenism, leading to an elevated risk of endometrial carcinoma. Fibromas are relatively common benign tumors composed of fibroblasts. They are predominantly unilateral and are generally hormonally inactive. Purithecomas are rare but may be hormonally active. Sertoli Leydig cell tumors commonly present with masculinization. Less than 5% recur or metastasize. Metastatic tumors. The most common metastatic tumors of the ovary are derived from tumors of Müllerian origin, the uterus, fallopian tube, contralateral ovary, or pelvic peritoneum. The most common extra-Müllerian tumors metastatic to the ovary are carcinomas of the breast and gastrointestinal tract, including colon, stomach, biliary tract, and pancreas. Also included in this group are rare cases of pseudomyxoma peritoni, derived from appendiceal tumors. A classic metastatic gastrointestinal carcinoma involving the ovaries is termed Krukenberg tumor, characterized by bilateral metastases composed of mucin-producing cancer cells with a signet ring appearance, most often of gastric origin. Gestational and placental disorders. Diseases of pregnancy and pathologic conditions of the placenta are important causes of fetal intrauterine or perinatal death, congenital malformations, intrauterine growth restriction, maternal death, and morbidity for both the mother and child. Only those disorders for which recognition of morphologic features contribute to an understanding of the clinical problem are discussed here. These include selected disorders of early pregnancy, late pregnancy, and trophoblastic neoplasia. Understanding placental disorders requires a working knowledge of normal placental anatomy. The placenta is composed of chorionic villi, figure 2246A and B, that sprout from the chorion to provide a large contact area between the fetal and maternal circulations. In the mature placenta, the maternal blood enters the intervillous space through endometrial arteries, spiral arteries, and circulates around the villi to allow gas and nutrient exchange. Figure 2247. The deoxygenated blood flows back from the intervillous space to the decidua and enters the endometrial veins. Deoxygenated fetal blood enters the placenta through two umbilical arteries that branch radially to form chorionic arteries. Chorionic arteries branch further as they enter the villi. In the chorionic villi, they form an extensive capillary system, bringing fetal blood in close proximity to maternal blood. The gas and nutrient diffusion occurs through the villous capillary endothelial cells and thinned-out syncytial trophoblasts and cytotrophoblasts. Under normal circumstances, there is little or no mixing of fetal and maternal blood, though sufficient free fetal DNA reaches the maternal circulation to permit prenatal genetic testing. Chapter. Blood oxygenated in the placenta returns to the fetus through the single umbilical vein. 1028. Gestational and placental disorders 1029. A. B. Figure 22.4. 6 normal placenta. A. First trimester chorionic villi, composed of delicate mesh of central stroma surrounded by 2 discrete layers of epithelium, the outer layer consisting of syncytiotrophoblasts, double arrows, and the inner layer consisting of cytotrophoblast, arrow. B. Third trimester chorionic villi, composed of stroma with a dense network of dilated capillaries surrounded by markedly thinned out syncytiotrophoblast and cytotrophoblast, same magnification as A. Disorders of early pregnancy, spontaneous abortion. Spontaneous abortion or miscarriage is defined as pregnancy loss before 20 weeks of gestation. Most of these occur before 12 weeks. 10 to 15% of clinically recognized pregnancies terminate in spontaneous abortion. However, using sensitive chorionic gonadotropin assays, it has been determined that an additional 20% of early pregnancies in otherwise healthy women terminate spontaneously, many without notice. In most individual instances, the mechanisms leading to early loss of pregnancy are unknown. However, multiple fetal and maternal causes of spontaneous abortion have been identified. Among the most important are the following: fetal chromosomal anomalies, such as aneuploidy, polyploidy, and translocations, are present in approximately 50% of early abortuses. More subtle genetic defects, for which routine genetic testing is not available, account for an additional fraction of abortions. Maternal endocrine factors, including luteal phase defect, poorly controlled diabetes, and other endocrine disorders. Physical defects of the uterus, such as submucosal leiomyomas, uterine polyps, or uterine malformations, may prevent or disrupt implantation. Systemic disorders affecting the maternal vasculature, such as antiphospholipid antibody syndrome, coagulopathies, and hypertension. Infections with protozoa toxoplasma, bacteria, mycoplasma, listeria, or a number of viruses. Ascending infection is particularly common in second trimester losses. Ectopic pregnancy. Ectopic pregnancy refers to implantation of the fetus in a site other than the normal intrauterine location. The most common site is the extrauterine fallopian tube, approximately 90% of cases. Other sites include the ovary, the abdominal cavity, and the intrauterine portion of the fallopian tube, cornual pregnancy. Ectopic pregnancies account for 2% of confirmed pregnancies. The most important predisposing condition, present in 35% to 50% of patients, is prior pelvic inflammatory disease, resulting in intraluminal fallopian tube scarring, chronic salpingitis. The risk of ectopic pregnancy is also increased with peritubal scarring and adhesions, which may be caused by appendicitis, endometriosis, and previous surgery. In some cases, however, the fallopian tubes are apparently normal. Another risk factor is use of an intrauterine contraceptive device, which is associated with a twofold increase in ectopic pregnancy. Ovarian pregnancy results from the fertilization and trapping of the ovum within the follicle just at the time of its rupture. Abdominal pregnancies occur when the fertilized ovum fails to enter or drops out of the fimbriated end of the tube. In each abnormal location, the fertilized ovum develops as usual, forming placental tissue, amniotic sac, and fetus. The host implantation site may also develop decidual changes. Morphology. Tubal pregnancy is the most common cause of hematosalpinx blood-filled fallopian tube and should always be suspected when a tubal hematoma is present. Initially, the embryonal sac, surrounded by immature chorionic villi, implants within the lumen of the fallopian tube. Trophoblastic cells and chorionic villi then invade the wall of the fallopian tube, as in the uterus during normal pregnancy. With time, the growth of the gestational sac distends the fallopian tube, causing thinning of the wall and rupture. Rupture frequently results in massive intraperitoneal hemorrhage, which sometimes is fatal. Less commonly, the tubal pregnancy may undergo spontaneous regression and resorption, or may be extruded through the fimbriated end of the tube into the abdominal cavity, tubal abortion. Clinical features. Rupture of a tubal pregnancy is a medical emergency. The clinical course of ectopic tubal pregnancy is characterized by the onset of moderate to severe abdominal pain and vaginal bleeding, 6 to 8 weeks after the last menstrual period. Chapter 22. The female genital tract. Fetal circulation, umbilical vein, decidua parietalis umbilical arteries, smooth chorion, amnion, chorioamnionic membrane, intervillous spaces chorionic plate. Myometrium, marginal sinus decidua basalis, anchoring villus, placental septum, endometrial veins, endometrial arteries, maternal circulation. Figure 22.4. 7 diagram of placental anatomy. Within the outer boundary of myometrium is a layer of decidua, from which the maternal vessels originate and deliver blood to and from the intervillous spaces. Umbilical vessels branch and terminate in placental villi, where nutrient exchange takes place, correlating with distension and then rupture of the fallopian tube. In such cases, the patient may rapidly develop hemorrhagic shock and signs of an acute abdomen. Rapid diagnosis is critical and is based on determination of chorionic gonadotropin titers, pelvic sonography. Endometrial biopsy, which shows decidua without chorionic villi or implantation site, and/or laparoscopy. Despite advances in early diagnosis, ectopic pregnancy still accounts for 4% to 10% of pregnancy-related deaths. Twin placentas. Twin pregnancies arise from fertilization of 2 ova dizygotic, or from division of 1 fertilized ovum monozygotic. There are 3 types of twin placentas, figure 22. 48, diamnionic dichorionic, which may be fused, diamnionic monochorionic, and monoamnionic monochorionic. Disorders of late pregnancy disorders that occur in the 3rd trimester of pregnancy are related to the complex anatomy of the maturing placenta. Complete interruption of blood flow through the umbilical cord from any cause, e.g. constricting knots or compression, can be lethal to the fetus. Ascending infections involving the chorioamnionic membranes may lead to premature rupture of amniotic membranes and delivery. Retroplacental hemorrhage at the interface of the placenta and myometrium, abruptio placentae, threatens both the mother and fetus. Disruption of the fetal vessels in terminal villi may produce a significant loss of fetal blood, resulting in fetal injury or death. Uteroplacental malperfusion can be precipitated by abnormal placental implantation or development, or maternal vascular disease. The effects may range from mild intrauterine growth restriction to severe uteroplacental ischemia and maternal preeclampsia, described later. Dichorionic diamnionic, monochorionic diamnionic, chorion. Figure 22.4. 8 diagrammatic representation of the various types of twin placentation and their membrane relationships. Modified from Gersel D. et al., Diseases of the Placenta. In Kermanar editor, Blaustein's Pathology of the Female Genital Tract, New York, 1994, Springer Verlag. 030. Dichorionic, diamnionic fused, monochorionic, monoamnionic, amnion, amniotic fluid, placenta, gestational and placental disorders, 1031. A BC figure 22.4. 9 placental infections derived from ascending and blood-borne routes. Acute chorioamnionitis. A. On gross examination, the placenta contains greenish opaque membranes. B. A photomicrograph illustrates a dense band-like inflammatory exudate on the amniotic surface, arrow. C. Acute necrotizing intervillositis from listeria infection. The space between the villi is filled with blood and acute inflammatory cells, neutrophils. The villi appear necrotic. Monochorionic placentas imply monozygotic identical twins, and the time at which splitting of the developing embryo occurs determines whether 1 or 2 amnions are present. Dichorionic placentation may occur with either monozygotic or dizygotic twins and is not specific. One complication of monochorionic twin pregnancy is twin-to-twin transfusion syndrome. Monochorionic twin placentas have vascular anastomoses that connect the circulations of the twins, and in some cases these connections include 1 or more arteriovenous shunts. Twin-to-twin perfusion syndrome results when these shunts preferentially increase blood flow to one twin at the expense of the second, causing one twin to be underperfused and the second to be fluid overloaded. If severe, it may result in the death of one or both fetuses. Abnormalities of placental implantation. Several types of abnormal placental implantations are associated with significant complications. Placenta previa is a condition in which the placenta implants in the lower uterine segment or cervix, often leading to serious third trimester bleeding. A complete placenta previa covers the preeclampsia is a systemic syndrome characterized by internal cervical OS, and thus requires cesarean delivery to widespread maternal endothelial dysfunction that presents overt placental rupture and fatal maternal hemorrhage during pregnancy, with hypertension, edema, and protein vaginal delivery. Placenta accreta is caused by partial or urea. It occurs in about 3% to 5% of pregnant women, usually complete absence of the decidua, such that the placental in the last trimester, and more commonly in women pregnant villus tissue, adheres directly to the myometrium, which for the first time primiparas. Some of these women become leads to a failure of placental separation at birth. It is in seriously ill, developing convulsions. This particularly severe important cause of severe, potentially life-threatening form of the disorder is termed eclampsia. Other complications postpartum bleeding. Common predisposing factors are stemming from systemic endothelial dysfunction include placenta previa in up to 60% of cases and history of previous hypercoagulability, acute renal failure, and pulmonary cesarean delivery. Edema. Approximately 10% of women with preeclampsia develop microangiopathic hemolytic anemia, elevated liver enzymes, and low platelets, referred to as the HELP syndrome, Chapter 18. Preeclampsia should be distinguished from gestational hypertension that can develop in pregnancy. 1. Ascending infection through the birth canal, and 2. Without proteinuria. Preeclampsia and eclampsia. Placental infections. Infections in the placenta develop by two pathways: hematogenous transplacental infection. Ascending infections are by far the most common and are virtually always bacterial. In many such instances, localized infection of the membranes produces premature rupture of membranes and preterm delivery. The amniotic fluid may be cloudy with purulent exudate, and histologically, the chorion amnion contains an infiltrate of neutrophils accompanied by edema and congestion of the vessels, figure 2249, AB. The infection frequently elicits a fetal response consisting of a vasculitis of the umbilical and fetal chorionic plate vessels. Uncommonly, bacterial infections may result from hematogenous spread to the placenta, leading to acute villus, figure 2249C. Several hematogenous infections, classically components of the torch group toxoplasmosis, and others, syphilis, tuberculosis, listeriosis, rubella, cytomegalovirus, herpes simplex, can affect the placenta. They give rise to chronic inflammatory cell infiltrates in the chorionic villi, chronic villus, and are described in Chapter 10. Chapter 22, the female genital tract. Pathogenesis. The placenta plays a central role in the pathogenesis of preeclampsia, as symptoms disappear rapidly after delivery of the placenta. The critical abnormalities in preeclampsia are diffuse endothelial dysfunction, vasoconstriction leading to hypertension, and increased vascular permeability, resulting in proteinuria and edema. Recent work has demonstrated that these effects are most likely mediated by placenta-derived factors released into the maternal circulation. Although the release of these factors and the clinical syndrome develop late in gestation, the pathogenesis of the disease appears to be closely tied to the earliest events of pregnancy and placentation. The principal pathophysiologic aberrations are proposed to be the following. Abnormal placental vasculature. The precipitating events in preeclampsia are abnormal trophoblastic implantation and a failure of physiologic remodeling of the maternal vessels, which is required for adequate perfusion of the placenta. At the implantation site of a normal pregnancy, fetal extravilus trophoblasts, cells not associated with chorionic villi, invade the maternal decidua and decidual vessels to destroy the vascular smooth muscle and replace the maternal endothelial cells with fetal trophoblastic cells, forming hybrid fetomaternal blood vessels. This process converts the decidual spiral arteries from small caliber resistance vessels to large capacity uteroplacental vessels, lacking a smooth muscle coat, figure 2250. In preeclampsia, this vascular remodeling fails to occur, leaving the placenta ill-equipped to meet the increased circulatory demands of late gestation and setting the stage for the development of placental ischemia. endothelial dysfunction and imbalance of angiogenic and anti-angiogenic factors. It is postulated that, in response to hypoxia, the ischemic placenta releases factors into the maternal circulation that cause an imbalance in circulating angiogenic and anti-angiogenic factors. This, in turn, leads to systemic maternal endothelial dysfunction and the clinical symptoms of the disease. In support of this, the blood levels of two placenta-derived anti-angiogenic factors, soluble FMs like tyrosine kinase, SFLTL, and endoglin, which antagonize the effects of VEGF and TGF respectively, are several orders of magnitude higher in women with preeclampsia than in healthy controls. In preeclampsia, high levels of SFLT1 and soluble endoglin bring about a decrease in angiogenesis much earlier than in normal pregnancy. The result is defective vascular development in the placenta. Furthermore, TGF-beta induces endothelial production of nitric oxide, a potent vasodilator. Thus, inhibition of TGF-beta by endoglin may directly contribute to systemic vasoconstriction, hypertension, and tissue hypoperfusion. Studies in animal models also implicate SFLTL and soluble endoglin in the pathogenesis of endothelial dysfunction. When SFLT and endoglin are overexpressed together, rats develop nephrotic range proteinuria, severe hypertension, and fetal growth restriction, the hallmarks of severe preeclampsia, as well as features of the HELP syndrome, including elevated liver enzymes, decreased 1 infarcts, which are larger and more numerous than those platelet count, and hemolysis. Thus, it seems that SFLT1 that may be seen in normal full-term placentas, 2 exaggerated and soluble endoglin, are key mediators that link the ischemic changes in the chorionic villi and trophoblast, consisting placenta to the characteristic maternal endothelial dysfunction of increased syncytial knots. Preeclampsia 1032 of Sion retroplacental frequent. Normal myometrium, syncytia trophoblast, decidua, tunica media. Fetal blood vessels, cytotrophoblast, cytotrophoblast. Column spiral artery, blood flow, maternal endothelial, cells, endothelial, cytotrophoblast, villus. Maternal blood, maternal vein. Preeclampsia, syncytia trophoblast myometrium. Decidua, tunica media, cytotrophoblast. Spiral artery, maternal endothelial, cells, maternal blood, maternal vein, figure 22.50. The physiologic alterations in the uterine spiral arteries and the failure of their remodeling in preeclampsia. Modified from Maynard S., Epstein F.H., Karamanchi S.A., preeclampsia and angiogenic imbalance. Anu Rev. Med 59 61 78 2008. Coagulation abnormalities. Preeclampsia is associated with a hypercoagulable state that may lead to the formation of thrombi in arterioles and capillaries throughout the body, but particularly in the liver, kidneys, brain, and pituitary gland. Hypercoagulability is likely related to the reduced endothelial production of PGI2, a potent antithrombotic factor, and increased release of procoagulant factors. Production of PGI2 is stimulated by VEGF, and women with preeclampsia have decreased endothelial production of PGI2, presumably due to antagonism of VEGF by SFLT1. Morphology. The placenta reveals several microscopic changes, most of which reflect malperfusion, ischemia, and vascular injury. These include gestational and placental disorders, 1033. Figure 22.5. 1. Acute atherosis of uterine vessels in eclampsia. Note, fibrinoid necrosis of the vessel wall and subendothelial macrophages. Courtesy Dr. Drusilla J. Roberts, Massachusetts General Hospital, Boston, Mass. Hematomas due to bleeding and instability of uteroplacental vessels. And 4. Abnormal decidual vessels which may show thrombi, lack of normal physiologic conversion described earlier. Fibrinoid necrosis or intimal lipid deposition, acute atherosis. Figure 22.51. The liver lesions when present take the form of irregular, focal, subcapsular, and intraparenchymal hemorrhages. On histologic examination, there are fibrin thrombi in the portal capillaries and foci of hemorrhagic necrosis. The kidney lesions are variable. The glomeruli show marked swelling of endothelial cells, amorphous dense deposits on the endothelial side of the basement membrane, and mesangial cell hyperplasia. Immunofluorescent studies show abundant fibrin deposition in glomeruli. In advanced cases, fibrin thrombi are present in the glomeruli and capillaries of the cortex. If widespread and severe, these thrombi may produce bilateral renal cortical necrosis. Chapter 20, leading to complete destruction of the cortices. The brain may have gross or microscopic foci of hemorrhage along with small vessel thromboses. Similar changes are often found in the heart and the anterior pituitary gland. Clinical features: preeclampsia most commonly starts after 34 weeks of gestation, but begins earlier in women with hydatidiform mole disgust, later, or pre-existing kidney disease, hypertension, or coagulopathies.